I will indicate that I was behind the development of the prevention and response strategies and mechanisms and systems of sexual harassment in Uganda. What we did then about 2 years ago, after developing this system, we rolled it out, had it implemented, and then afterwards, when we were supposed to be doing the review of it to benchmark the lessons and take stock of how it is performing, somehow the funding ended and we stopped it at that. But I think there are hopes that it will be picked up once again. We benchmark the lessons, see how it is performing, see the weaknesses and how it can be made better. So I think that is the background against which I'm going to be speaking to you today. And before I start us off, let me first take this opportunity to thank you very much for reaching out to me and asking me to share experiences from Uganda about what we did. And I don't think that an hour will do justice to what I'm going to be talking about, but I'm open and willing to do more sharing with you as time goes on. So I have come up with an elaborate presentation, but which is not exhaustive. And so I will run through it for want of time. I may even skip some slides. And in future, in case you want us to share more, feel free to reach out to me. So without further ado, allow me to please share my screen and make the presentation. Can you see my screen?
Yes, please put on the slide show mode. Yes, thank you.
Okay. So I was asked to talk about prevention and response to sexual harassment in the health sector workplaces, lessons from Uganda. And that's what I will do. Maybe some of us, and I'm not here to educate us because I know that some of you or all of you already know what it is. And so I'll go straight away to talk about the definition that we adopted in Uganda based on the law that is prevailing both at national and international level. And again, for want of time, I will not go through all these laws because we don't have time to do that. But we looked at it as anything that is, as any unwelcome sexual behavior which makes a person offended, humiliated, or intimidated. And so when we are talking about sexual harassment, whatever the action of that sexual nature should be, it must be capable of creating an offense, which is the reason why we are talking of someone feeling offended or humiliated or intimidated. And most of the times it happens at workplaces, as opposed to what happens on the streets or in lodges or any other environment. It tends to show more or to happen more in workplaces. And so it also entails unwelcome sexual advances or requests for sexual favors, which may be verbal or physical or graphical, as I will be, explaining later on in my presentation. And so it is founded in Uganda. That definition comes from the Employment Act, which seeks to guide the relationship between the employers and employees, and also address and handle issues of sexual harassment. And that Employment Act, specifically Section 7, Paragraph 1, defines sexual harassment defines sexual harassment to mean, whether an employer or his representative indirectly asks an employee for sexual favors or does a sexual contact or any form of sexual activity which is contrary to the law, and that amounts to sexual harassment. You do not have to have sex with this person for it to become sexual harassment. Only a gesture is enough for that act to become sexual harassment. Here I'm going to talk about the prevalence rate in terms of statistics in Uganda of sexual harassment. We started with a study in 2012, and then this was followed later on in 2016 with another study. The first one was on gender discrimination impact analysis, which established that there was sexual harassment in health sector workplaces, standing then at 32.1%. And so this prompted us in 2016 to do a formative sexual harassment assessment study to establish what magnitude, what form, how does it present, what are the causes, what are the consequences, and how it can be prevented. And so the two studies indicated that at least 1 in every 3 health workers are experiencing sexual harassment at the workplaces. And it normally presents either as hostile environment or quid pro quo, which means this for that in terms of forms, and that the majority of victims were females compared to their counterpart males. And the most common form of sexual harassment that was being experienced then and possibly now was quid pro quo, this for that. You give me sex, I give you a promotion. And the majority of the perpetrators were identified in these two studies as men in senior positions, more especially the supervisors, the in-charges, and all that. For purposes of today's discussion, I will focus more on the health sector workplaces, but it is important for us to note that sexual harassment happens everywhere in many different workplaces beyond health. So we established from those studies that the following are categories and forms of sexual harassment. Like I indicated, quid pro quo was the first kind, which is this for that. And it is a kind of blackmail in that a person's rejection of someone's request or suggestion to have sex with them can cause an adverse effect on their employment, on their job, on their performance, on their promotion. So, meaning that you sell sex in short to get a promotion or to get a favor or to be merited or to be credited for anything. And this is typically practiced by people who have more power than the victims or power to make job-related decisions, such as supervisors. And this is what was established to be the common form of sexual harassment in Uganda. The other form is hostile environment. And this presents as unwelcome behavior. It becomes pervasive or offensive behavior. It can become sex or gender related. It can interfere with the opportunity to work. It can present as a threat. It can intimidate and make the whole person's or the employee's presence at work very uncomfortable. It can even lead to dismissals, it can lead to demotions, it can lead to even refusal to pay salaries or delay in payment of salaries and all that. Whereas for quid pro quo, you will discover that under quid pro quo, the two parties are willing, but one of them is being coerced to exchange sex matters they may not be willing for purposes of getting the favor, of buying their way. I hope that distinction is clear. And so what I want to say is that hostile environment sexual harassment does not always happen suddenly. It may occur over a period of time. It can take even a year, even 3 years, even, it can go on and on and on. It is not a one-off kind of transaction. However, a single outrageous act can also fall into this category. You do not have to, repeat the act for it to become sexual harassment, even a one-off. Say if I'm told that there is a man who used to go to the ladies for his short calls and wait for women to molest them there. So even if it happens there once, that can qualify as sexual harassment, much as it is happening for the first time. It normally manifests in 5 different ways. It can manifest physically, it can be verbal, it can be gestural, it can be written or graphic, it can be psychological or emotional, and I'm going to explain that. Can you see that poster? Can you see it?
Yes, can see
okay.
it. Yeah.
If you look at for example, at the first picture on your left, you see that touch. The man or someone saying you have a sexy body. That can be sexual harassment. The next one, you see someone presenting their CV to a potential employer, and all the employer is saying is that if you give me happiness today, I will give you a job. That is quid pro quo. Someone is pegging the offer of a job to sexual harassment. You look hot today. Then you can also, someone is holding a laptop there saying sex. Why shouldn't we try this out today? And all this is happening at the workplace. Then others bring unsolicited gifts. Every day you bring a flower, you bring someone, you give them endless compliments. You're smart, you have a great body, you have a great smile every day. That can also amount to sexual harassment. So examples of sexual harassing behaviors could include unwelcome touching, staring or leering, suggestive jokes or comments, sexually expressed pictures, posters, screensavers, calendars. There is a WhatsApp platform where I use it to be. And we had someone who would send pornos and nudes. Many times those things would put us off, and some of us had to exit. That could, in a way, become sexual harassment, especially if you target a particular individual. If you keep sending me such pictures, such posters, such screensavers, such, you are sexually harassing me. Unwanted invitation to go out on a date. But this should present itself to more regularly. Requests for sex, intrusive questions about one's private life or body. insults. When you refuse, then they begin to insult you, to call you names, to taunt you based on your sex. Then sexually expressed emails, text messages, and all that. And these are common at workplaces. But now I know in Uganda, we were faced with a question about when do you make a distinction between sexual harassment and mere flirting? When do you tell that someone is, serious or is just, what if he wants to marry you? Why should you take it as sexual harassment? And if you report him as such, then where will you get a husband? So we came up with this distinction. A mere flirt, if you're flirting with someone, if you flirt with me, for example, and I flirt back, it means it is a welcome conduct. I'm not offended. You remember the offensiveness that I talked about from the definition. But sexual harassment presents itself as something that is unwelcome. If you crack a joke that I do not buy, please then take it back and don't do it again. If you repeatedly bring it and I don't answer back and I don't flirt and I don't joke with it, then it means that you're offending me. Flirting goes both ways. We are all interested, we exchange. But sexual harassment is always one-sided. And then flirting does not make someone feel bad, but sexual harassment is offensive. It will make one feel bad. And what is important for us to notice that it does not matter if the harasser says he or she did not mean it. What matters is how it makes one feel. If you touched my boobs, for example, and I said I'm offended, that may not do what? Take away the fact that you did not mean it. I mean that it is, if you did not mean it, if you thought I would enjoy it, and I feel bad, it is sexual harassment. It's not about what you intended, it's about how I have felt. And so from our studies, we discovered that the victims and perpetrators of sexual harassment in the health sector workplaces, most of the times are the following. We have the health workers, both subordinate and those both in subordinate and management positions, and also at peer-to-peer level. Again, patient to clients. In Uganda, we had situations where the doctors raped their clients or touched them or molested them or did some sexual kind of conduct that did not augur well with their clients. And the fact that you are in a management position or you are a supervisor does not mean that you are immune to sexual harassment. You can still be sexually harassed by your juniors. In Uganda, we have this commissioner who gave us a personal testimony, a lady whose driver was busy sexually harassing using a different medium of communication, like SMSs and everything. So being in a senior position does not mean that your junior cannot harass you. So what I want to say here is that anyone can be harassed just as anyone can be a target of harassment. Anyone can harass and anyone can be a victim of harassment, regardless of your sex, age, profession, or professional position, or seniority in the organization where you are. But from our studies, we established that the majority of victims were commonly women in junior positions, and the perpetrators were commonly males in management or managerial positions. And so this repeats what I have been talking about. it can happen to any of those victims and perpetrators. It can be a supervisee or a supervisor, peer-to-peer. It can be managers or in charges, men, women. It can be anyone. Volunteers, interns, and all that. And so we normally have myths. Unfortunately, we are doing virtual interaction, and I may not be able to see you and ask you questions, so we cannot interact. But there are myths surrounding sexual harassment at the workplaces, which make it continue unabated because of the myth surrounding it. One of them is that sexual harassment is rare. The seriousness of sexual harassment has been exaggerated. If I'm expressing love, why should I be, taken as a harasser? Others think it is a mere harmless flirtation. If the harasser does not do it intentionally, then it does not constitute sexual harassment. And the intention cannot be told. It is only God who can tell your intention and yourself. So many people, the harassers, will come through and say, I did not intend to offend you, but I'm offended. Many workers make up reports and stories, and indeed in Uganda we established that. Whereas it is true that a worker can come up with an allegation of sexual harassment against their boss to cover up their weaknesses in performance, many times it is not the case. Many times it is true, and then the bosses will come around and say, we were lied against because they are poor performers. And others believe that if you ignore sexual harassment, it will go away because the harasser will notice that you are not interested and he will give up. And also there is a myth that victims of sexual harassment are all female, which is not true. Even men have been harassed. And in Uganda, we have statistics to that effect, but I do not have time to pull all that out. So what are the causes of sexual harassment? We noticed that there is a lot of unequal power and relations, abuse of power and authority, negative cultural practices, lack of knowledge and information, lack of proper and clear reporting and response mechanisms, which would even ensure confidentiality. Women and men do not want to come out and identify themselves, and then the following day it is on the news, it is on the street, it is being shared in the corridors. So the victim would rather hide it. Gender-based discrimination, dependence on other co-workers, and all that. I'm going to be a little faster. I'm not saying that I don't have enough time. Please, I need to be prompted on when to stop. So the consequences are very glaring. It's at individual level, at organizational level, and at community level. And it can have health implications, which can present as psychological, physical, or sexual in nature. Take an example of a rape. The rape comes with a whole host of many things, including STDs, including HIV, including unwanted pregnancies. Hello, yes, they are not there. Excuse me for that. So that is those are the consequences. I have shared the presentation with John. He will send them to you, share it with all of you. But here we have categories that are affected. The victims, the perpetrators, all have consequences. Some of those are loss of respect, depression, late salaries, being paid late, and that is to the victim, demotions, then poor performance, absenteeism, loss of confidence, and at worst case scenario, they can get into secondary trauma. For perpetrators, they can even face criminal charges, civil claims, poor performance, they cause conflict at work and loss of respect and all that. This you will read. When you come to health service organizations, like the hospitals, health centers, medical centers, in Uganda, we discovered that there is a lot of absenteeism when there is sexual harassment taking place. Whether it is, quid pro quo or hostile environment, people tend to absent themselves because they are tired. Others, there is high attrition rate through dismissals, resignation, and transfers, low productivity, lack of promotion, professional dissatisfaction. We can name it at society level. There is limited or decreased productivity, poor health outcomes, violations of human rights, and all that. So what did we do in Uganda? After doing those 2 studies, and we came up with more evidence that pointed to the problem that needed to be acted on, we moved in quickly. I had the opportunity to lead the team that was developing a prevention and response system for the health sector. First of all, we started by engaging the Ministry of Health leadership so that they could own this system that we were developing to ensure that they are part and parcel of it and they own it and implement it. Then we embarked on social behavior change communication through IEC, through television, talk shows, and all that. Then we developed guidelines for sexual harassment prevention and response because we did not initially wanted to come up with a policy. Then later we stopped that because we felt we had a strong legal regimes in Uganda that provided against sexual harassment. What was lacking was the implementation, and what we needed was to pass the guidelines that would actualize or support the implementation process. And so we did that. In the guidelines, we established an effective system for reporting. We engaged with the health professional councils who are charged with the discipline of the health workers and also licensing. They became active members of this system. They integrated sexual harassment aspects in their codes of conduct and started holding their membership accountable. And then we integrated and sustained sexual harassment prevention and response in the existing structures and systems of public service, of rewards and sanctions committees, of promotion and performance management. And then we did a lot of research and evidence-based reviews. And so we took further actions to consolidate the response. One of them was to constitute the Ministry of Health Sexual Harassment Consultative Committee, which was established. We trained the Ministry of Health, Regional Referral Hospital leadership and management, and the health sector employees on sexual harassment and response. We established a rewards and sanctions committee at all levels to ensure that they oversee the implementation of these guidelines and the law. We designated and trained sexual harassment focal point persons at all levels. We revised the health professional council's codes of conduct to include aspects of sexual harassment and their sanctions. We issued through Ministry of Public Service administrative circulars to all public servants within the health sector on how to address sexual harassment and implement the guidelines. And like I indicated at the time, the funding stopped, we were at the level of reviewing the initial implementation, but at the beginning we had rolled it out nationally, and now we were going to give it 6 months of initial implementation to go back and review, take stock, and then redesign for purposes of scaling up. So what are the prevention strategies for sexual harassment? Like I indicated, sexual harassment affects individuals, it affects institutions, and it affects systems, it affects management. It does not disappear on its own, and that means that it must be acted on by the management, by different stakeholders. So we came up with the following strategies for prevention: primary, secondary, and tertiary, and I'm going to run through them. At primary level, these are strategies you put in place before sexual harassment occurs to prevent initial perpetration of victimization. And then this can be done through awareness raising, training of various stakeholders, and ensuring bystander interventions are in place. So I will share this. I don't want to be caught by time, but primary prevention happens before sexual harassment takes place, so that it is preempted. And many people commit sexual harassment because of lack of knowledge and awareness. For secondary strategies, secondary prevention strategies, these are immediate responses after sexual harassment has occurred, and it deals with short-term consequences of harassment, and it includes measures used in high-risk situations to stop emerging abuse and progression. So under here, you have to create effective reporting, you have to provide counseling to the complainants, you have to ensure that there is that perpetrators are counseled and disciplined accordingly so that the habit stops. You have to put in place a prompt investigation mechanism to address all the complaints. Because if you don't, then the potential harassees or victims will lose trust in the system and they cannot come forward to make a complaint. Then you also have issues to do with protection being provided, referrals to police, to legal aid providers, to protection shelters, to specialized counseling, and all that. Then tertiary level prevention strategies deal with long-term responses for sexual harassment. And here we look at lasting consequences. And so we are looking at issues of psychosocial services, referring victims and perpetrators for specialized treatment and management where there is need. So when it comes to reporting, we put in place the following reporting system because we discovered that sexual harassment continues to go unabated because of poor reporting system. And so reporting system is very key in responding to cases of harassment, and its effectiveness is hinged, the effectiveness of the response is hinged on reporting. So in Uganda, we put in place a sexual harassment focal point person at every health facility. We put in place a call center to receive complaints of sexual harassment nature, and this allows even anonymous reporting. We put in place a system for suggestion boxes at every center. If you are not confident enough, you can drop your complaint in the suggestion box which we proposed could be situated in the bathroom, because everyone visits the bathroom anyway. And then reporting to the supervisors and then the health professional councils who are charged with the screen issues of their membership. Barriers of reporting. We discovered that there are several barriers of reporting, which are to reporting, which hinder victims to come forward. Some of them include gender myths. You know, how can I, if you're a man, how can I report a woman harassing me? And so in Uganda, we say men enjoy sexual harassment because they cannot come forward and report. There are gender myths. There is fear for retaliation and punishment. There is fear for victimization. There is a lack of clear mechanism of reporting, fearing to lose the job, and all that. And so when it came to filing a complaint, we put in place three means of registering a complaint. One, a direct victim of sexual harassment can report. An individual indirectly affected by consequences of sexual harassment can report, and the bystander can report. So I will try to define the last two, because the first one is clear to me. Direct victim, you are the one who has been harassed. So you can go and report. But also, if I'm your colleague and you're coming late every day because, or you have absented yourself every day because your boss is harassing you, I can take it upon myself and file that complaint on your behalf. A bystander is that willing party who says this girl or this boy is being harassed. They do not have the confidence to report. Let me take it upon myself and report on their behalf, much as they may not be affected or by the consequences of that act. That is a bystander. And so we put in place two complaint handling procedures. One is the informal procedure, which aims at both parties reconciling, resolving the complaint, agreeing on the acceptable behavior, and on non-retaliation. But again, there is an arbiter that oversees this whole process of informal procedure. So that one, you do not have a formal complaint. There is a formal complaint, but it does not go to the record for purposes of future reference, unless you do a repeated action that will cause it to be resurrected. Again, like I indicated, this is a subject that is so wide, I may not conclude it in 1 hour. Then on formal procedure, we looked at predefined steps that must be followed from the time of reporting to how the investigations should be conducted, to making of the reports and on the findings of the investigations, and then the actions that should be taken, to the appeal procedures, and also to sanctions. So that is the formal bit. When we interact in future, I will take you deeper in these issues. So possible sanctions that we thought could be given out to the perpetrators, depending on the gravity of the matter. One could be a verbal warning, it could be a written warning or reprimand, it could be a demerit, it could be a demotion, it could be a dismissal, depending on the gravity of the matter. It could be an interdiction, depending on the gravity of the matter, depending on the prevailing legal provisions in a given country. So, thank you very much for listening to me. This brings us to the end of my presentation. So I had to run through it so that if you have any questions, then we could have them entertained. Over to you, Chair.
Thank you very much. Thank you very much for that wonderful presentation within the timelines. We thank you, Madam Alice, and all the participants who are just joining in. We are on sexual harassment, and we welcome you at this juncture to just highlight a few issues and the key people that I would want to highlight a few issues. I don't know whether I have Madam Jennifer is in.
No, she was delayed a bit. She has not joined.
Okay.
But we have Madam Raheli and Stella are on.
So at this juncture, what I want all of us to note from Alice's presentation, the summary is very clear, that it is not about what you intended, it is about what I've felt. I think that's the bottom line, Madam Alice.
Yes.
In the hallmark, what I've summarized from your presentation is that it is not about what the perpetrator intended, but it is what I have felt. Because if I felt bad about the harassment, then it is sexual harassment.
Yes.
So I would want this juncture to just invite Stella, Madam Stella Gidaiga, just make a 1 minute overview of what has been presented and maybe some additional contribution before I look at it from another perspective also.
Thank you, Mr. Karilas. Thank you so much, Madam Alice. Quite a comprehensive presentation and quite informative. We have learned quite a lot. As healthcare workers, I think we're in a very unique place because of our unique working conditions. And maybe some of these issues have been experienced at the workplace, but because of some of the points you've brought out, maybe people do not, first of all, realize that it is actually sexual harassment. And then again, when they realize, who do they report to? How do they report them? The issue of the unique shifts that healthcare workers cover, night duty, working over weekends, and probably through the holidays when a lot of the other employees are away. Could it be one of the places, one of the ways that could actually encourage the perpetrators to sexually harass their victims? I represent nurses that form a larger part of the healthcare industry. And to be quite honest, we have received quite a number of such complaints, some of them very subtle. And sometimes somebody is telling you and they probably don't know that it is actually sexual harassment. And so you encourage them to report. And I'm happy that we are having this discussion, Madam Alice, and I'm hoping that we can take some of the lessons from Uganda and incorporate them into our system. Thank you, and over to you, Chairman.
Thank you, Madam Stella. At this point, I would have wished to say that Mr. Fleming, but seemingly is not, I'm not seeing him on board. Dr. Kenothi, are you seeing Mr. Fleming?
Or let me get him on. Let me just get him on. Yes.
Because there is a perspective from the legal perspective that we also wanted to get clearly from this. But in the meantime, also I would wish to welcome Madam Raheli Mukwana. If you are around, you can make a remark over the whole issue of sexual harassment and your experience in the health sector and in nursing.
Thank you,
about 3 minutes.
Yeah, thank you, Karilas. Thank you, Madam Alice, for that very informative presentation. Actually, sexual harassment is something that is there, but most people do not report. And I want to agree. I think we suffer the same fate as Uganda. What's happening in Uganda is not very unique. I think this is something that happens all over. And I was just wondering during this presentation, is there a possibility where the health worker may be harassed by the patient? And I don't know, I've not had, I don't know if Madam Stella has had anything of the sort, but I think this is something that is not reported. And I wish we could get the prevention strategies the way Uganda has gone. You know, the three prevention strategies, the primary ones, secondary, and the tertiary ones. And also to say, you were talking about myths. There's this one myth that people think women say no when they mean yes. Yeah, this is something that I think most of them, most of the perpetrators think that when you harass a woman, when they say no, they mean yes. Yeah. Well, thank you.
Okay. Okay. Thank you so much, Madam Kwana. And I think to Madam Alice, there is the integration of our rural concept and philosophy and beliefs, and tying it to the now modern and organizational policies. How I would have wished to listen to some comment regarding that, so that you ensure that you integrate and intertwine those cultures which believe certain, even touching a lady would be normal, but others believing that touching a lady is not normal, and then integrating it with the legal framework that is in place, both locally and in Uganda.
I'm afraid I have not understood that question.
I want to understand, you know, with your experience on the ground, you must have interacted with the local culture and the dynamics of what they consider as normal, which in law may not be normal. So how have you managed to intertwine this such that you are able to sort communal issues where you reduce conflict? Because when you report certain type of behaviors which to them are normal, then it becomes a conflict. And how you do integrate it into the overall national policy and the legal framework?
Okay, thank you. Colleagues, if I may come in to respond to some of the questions that have been raised. And no meaning yes. I agree very, very much that in Uganda, that was one of the issues that we really faced. Many men came forward to say, you know, how will I prove that she does not like me? As a man, I have to chase. As a man, I have to really, you know, hunt. I have to give a run until I succeed. I have to persist. Otherwise, I will be considered as a weakling. And many people think that when a woman says yes, I mean, when a woman says no, she's in essence saying yes. But we are adults, ladies and gentlemen. When a woman says no, especially from the African perspective, if I'm saying yes in a no, you will know. Through my conduct, through my behavior, through my gestures. But also when I'm giving my firm no, you can tell it. Am I right? I'm sure you can tell it. And so if you have asked me out once or twice and I have said no, why don't you rest? The fact that you continue to push until I break and give in, if you don't get lucky and I break, then it becomes sexual harassment. And so that's why it should be, you know, stopped at that point. If I'm giving you a yes in a no, you will know. I will give it with a smile. I will give it with some softness, and you will see that there is a possibility that there is an open door. Because even when I give you an automatic yes, as a woman who wants to get married, you will run away from me. You say, this is a prostitute. That is the paradox in Africa, unfortunately. So as a woman, as an African woman, I'll give a soft no when I'm actually telling you yes, and you will see it in my conduct. So, and that's where many perpetrators hide to continue the perpetration. And this is where we, as managers, as responsible stakeholders, as health workers, must come through and say, we set the guidelines, we set the parameters that others must adhere to. I think it was Stella who commented on the work environment, which should be creating avenues to facilitate the perpetrators to commit sexual harassment. In Uganda, I want to agree with you, it is yes. In Uganda, we found health facilities that had, for example, one toilet shared by both men and women. And you have one changing room for both sexes on night duty. And you have a man and a woman doing the night shift. And there is only one changing room. What do you expect? So what happens is that the work environment that we have established alone makes it hard for health workers to resist the temptation. And therefore, it creates an avenue for perpetrators to take advantage of that. And I'll give an example from our experience in Uganda. There is a story we heard of a man who would first do his rounds at night. He would do the deliveries at night of his patients, pregnant mothers. He would deliver them at night, and he would ensure that he would first sleep with the nurses that he would work with. So before they wheel in the pregnant mother to the theater, he would first go there with the nurse, do his round or two before he could wheel in the patient. And that happens a lot. So, but we think, and some of the guidelines we put in place was that, when it comes to taking care of the patient, it is very important that at no single time should the patient be attended to by one person, especially if it is of a different sex. And therefore, we recommended in the guidelines that 2 health workers should attend to a patient, especially if they are of 2 different sexes, the patient and the health worker at one given time. And then we also recommended creation of separate facilities, sanitary facilities, changing rooms, clearly marked for men and women. So that is one. And then on the issue of situations where a health worker where a patient can harass a health worker, I want to agree with you, Stella, that yes, it happens a lot in Uganda, though the magnitude is at the level of health worker to health worker and health worker to patient. So what happened in Uganda, I think the statistics put it at 3%, where the health workers, the patients come through and harass the health workers. But remember what I defined sexual harassment to mean. It carries with it the power dynamics. One has to wield power over the other. And so many times patients are at the mercy of health workers. And therefore it becomes so hard for them to really come through and harass the doctors or the health workers, but it happens. I know of a particular story where one of the doctor friends of mine was being harassed by a girl who would carry her breast every day to him and say, "Press it, it is hurting. Please look at it." She strips and said, "Please examine it." And the doctor every day, and the doctor was feeling so bad because he felt he was being harassed. So it happens. On the cultural impact, if I understood your question very well, you are asking the acceptable things, acceptable practices by certain cultures vis-a-vis the law. If that's what you are asking, when we were developing the guidelines, we were guided by about 3 things: by the studies, the evidence we had collected, including the information in terms of mitigation, the law that existed in Uganda, and then the consultations. We consulted widely and we agreed on acceptable standards. And I agree, when it comes to gender-related dynamics, when it comes to sexual harassment, when it comes to violation of human rights, culture plays a very big role. And many times, these are the cultures that tend to be looked at as negative cultural practices, which end up affecting individual enjoyment of their rights. And so how we have gone about that is that after developing the set of acceptable standards and practices and guidelines, we went into awareness creation and helped people to appreciate that when you behave that way, you are actually going overboard. You are actually violating someone's enjoyment of their rights. You are actually doing something which is not right. And slowly, we started seeing positive responses from different cultures, from different stakeholders, from different people. So I don't know whether that was the question you asked. Then I saw some other questions in the chat box. Let me see. Do you have guidelines reporting means in your facility? What has been the challenges? Like I indicated, we have the guidelines that set out the reporting mechanism, both formal and informal, and different duty bearers have been put in place to address those concerns. Now, when it comes to challenges, when it comes to the challenges that have been experienced, like I indicated, after we had rolled out, we wanted to go out and study and evaluate, but unfortunately we ran out of the funding and we did not follow up. So possibly when we get the money to go and take stock, we should be able to know what exactly is, what actually happened. Then I saw another question from Titus. What happens when the harasser is your big boss and there is no anyone who is above him or her? Yes, we provided in the guidelines a clear reporting procedure where you can bypass him. I'm sure unless it is the minister, even if it is the minister heading the Ministry of Health, then you can even escalate it to Ministry of Public Service. In the case of Uganda, that minister can be held accountable under public service, can be held accountable under the courts of law, can be held accountable by the Public Service Commission, because they serve under that, and they are rules and regulations that govern their conduct. And so there is no one who is above the law. Even if he's the topest person, they can still be brought to account. And so in Uganda, we provided that kind of a procedure that can be taken into consideration. I saw another question. What action can be taken? This is from Renson. What action can be taken to those bosses who take advantage of ladies so that they can be given jobs? In case where a patient explains to you that she was tricked by a man taken to their house, but ending up being forced to have sex, what action can be taken? I'm sure I have explained that in Uganda, of course, I do not know what you would do in Kenya, but in Uganda, you can take any action, including reporting it as a crime, but also as an indiscipline under the administrative procedures of a particular organization, institution, or ministry. And so actions can be taken against that person. I have already taken you through the sanctions. One can be interdicted, one can be dismissed, depending on the gravity of the matter. One can be warned. Patrick says that allegations of sexual harassment have been used as a tool for blackmailing, especially men in senior positions. Many have had to settle matters for fear of publicity. What measures do you have in place to avoid this? I agree with you, and I said it in my presentation, that some people have used allegations of sexual harassment to blackmail their bosses, saying, you know, they harassed me, when actually they are trying to cover up their misdeeds at work. And that's why in place we have established a clear investigation mechanism. If surely you're lying, there is no crime or there is no misconduct that you can completely fail to have evidence that can support your allegation. And also, if you're lying against me, and I'm saying he is lying because I tried to hold him accountable for his poor performance, that's why he's saying this, then I should be having evidence to show or to prove why I'm saying that. So there is always something that will come through, and that's why you have to appear or to go through an elaborate investigation process. And then, of course, what can we do to avoid that situation? That's why we have to do training, create awareness and sensitization so that such situations can be avoided. But also an effective reporting and response mechanism must be established so that the potential perpetrators, the potential victims have confidence. If I have no confidence, then I will not report. And so if I report, I should have my case well investigated. If it is poorly investigated, then you will lose confidence, and such scenarios are likely to come up, saying, you know, he has harassed me and I don't have trust in this system. How does Macduff, how does one handle harassment on social media, e.g. erotic forwarders, WhatsApp? Thanks. Okay, in Uganda, recently we had an interesting case involving an MP with a secret admirer who harassed her a lot on social media until the MP decided to report the case to police. It was investigated, taken to court, and it was found to be harassment, cyber harassment. And the gentleman was sentenced to, I think, 3 years. He appealed against the sentence. The High Court overturned it, but now there is also an appeal from the gender activists in Uganda, which is yet to be settled. But social media harassment can be challenged. It can also be managed. Should I stop it at that?
We are just looking at
You
when
continue.
you can summarize. Yes. You can summarize because I'm seeing there are a few which are remaining. They're just few. Just finalize.
Okay.
Yes.
So Penina says someone who has been sexually harassed by a relative and after reporting you are threatened, what should they do? That is what I called retaliation. If you have been harassed and you're being threatened, that is again a crime. It is a crime you can report to police, you can report to if you are a member of if you're an employee, you can report to your organization, you can report even to self-help institutions that are charged with protection of victims of that nature. Any incidents reported at KNH, that is yours to answer. I'm not a Kenyan, unfortunately. Even informally, should it be encouraged that a perpetrator and victim should resolve the issue themselves, especially where the former holds the position of authority over the victim, or when would this be best applied? I agree, this is a very good question. We do not encourage that there should always be an amicable settlement. That's why we insist on documentation so that it forms a record, much as it may not be used against you. If someone is ready to apologize and it is ended, that's fine. And it cannot be ended by two people, a victim and a perpetrator. There has to be a third party, and this third party is the sexual harassment focal point person we designated. I don't know in Kenya how you will do it, but there has to be a third party who acts as an arbiter to witness that. And in future, should the practice repeat, then someone can come forward and say, yes, it happened in the first case. This is how we resolved it. It was amicable, and now he has repeated it. And you know what that means when it is escalated, it becomes a tough and uphill task to get rid of. How about men being harassed by lady bosses? Anderson. In Uganda, we have not yet, I don't think I have an experience in this. I have not had any experience in this, but I know it happens. And I think when it happens, you treat it the same way like any other type of harassment. But like I indicated, men always find it challenging to come forward and say, I'm being harassed by a woman. Others enjoy the harassment. They say, hey, she has brought herself, let me give her what has brought her. And so that can what? That can, I think let me stop it there. We are overshooting. I'm also charged with other things I want to run and do. So, but I'm also available to be reached on email, and I can always have another interaction in future with you. Over to you, Mr. Chairman.
Okay. Thank you so much, Madam Alice. I think we all appreciate the contribution of Madam Alice towards dissecting this issue of sexual harassment. And what we take note is that in most almost all organizations have work-related issues to do with the sexual harassment. And it is therefore important, it was therefore important to organize such a forum so that we share experiences globally and locally so that we know where we stand and how we move forward and integrate it with the legal framework which is there globally, starting with the ILO conventions and ratifications which have identified this as an issue that needs to be sorted at the organizational level, because the bottom line is that if we go with what Madam Alice says and what we've also experienced, that an institution with cases, so many cases of sexual harassment, you would find that performance is greatly affected. And even the organizational reputation, where you could attract even the best, is highly affected. So it therefore means that we have to do so much individually and collectively to help sort this. Without much ado, because time is running, I would want to call on just one comment from Dr. Irene Nwani, the Senior Director, Clinical Services, just in relation to the same, and then I'll revert back to the host so that we finish on time before we are shut off. Karibu, Daktari.
Good afternoon. Thank you very much, Chair and the coordination team for putting together this very important webinar. I'm particularly interested by the fact that we are in the process of adapting the Kenya National Guidance on Management of Harassment at Place of Work and for our hospital. And this has been very insightful. We would like to truly thank our Ugandan colleagues for sharing their experience and how they are managing this. We have a lot to borrow from them, and that this collaboration has started. We can continue learning from each other. Thank you to the team that has organized this, and we will continue with this conversation. And as we go ahead, I hope our Ugandan counterparts are open to continued collaboration so that we can have this problem best addressed in our institution, and also to help the other institutions represented by the participants of this address the same in their institutions. Thank you very much, Makafulo, and thank you very much for the good coordination of this webinar. Asante sana.
Thanks so much, Daktari. I also wish, before I transfer or I take back to Dr. Kinuthia, to thank Madam Alice and all the participants. It has attracted about 800 members. That's a good show that we are interested in sorting issues in our organization. And the only way you can sort it is to be empowered and to understand the nitty-gritties behind sexual harassment, so that tomorrow we are able to report them, to take note, and to take the necessary action which is appropriate, decisive, and within the framework of the legal framework that is put in place in our different institutions and different countries. With those many remarks, I would wish to take back the program to Dr. Kinuthia, the host, to finalize with these remarks. Dr. Kinuthia is around? Doctor? Okay. Imeisha. Amen.
Yeah, thank you, everyone. We had a small problem with the internet, which dropped, but the meeting is over and the recording will be available at the hospital website. Thank you, everyone.
Thank you. Good
Thank
night.
you. Bye.
Yes. Bye, bye.
Yes.